Good evening, all the aspirants present here. Today's speaker we have here is Dr. Avishek Roy, who is an associate consultant in ICU Apollo Multispeciality Hospital. The more aspirants will be joining us soon. You may take over. Thank you.
Okay. So, good evening, everyone. So, I'll be starting. Today's topic of discussion is rhabdomyolysis and contrast-induced nephropathy. So, my first topic would be contrast-induced nephropathy. Although classically we were taught that it is CIN or contrast-induced nephropathy, however, the recent terminology suggests that it's not contrast-induced, rather it's contrast-associated nephropathy or contrast-associated AKI. So the definition wise, as per KDIGO 2012 criteria, if you have a patient with acute kidney injury that is suggested by a rise of creatinine by absolute value of zero point 0.5 mg per dl, or that is in 44 microvolt per liter, or more than 25% increase than the baseline value within a specified time frame, that's within 48 to 72 hours of using a contrast media, and there should not be any background history of or background feature of any other coexistent renal disease or renal any kind of other pathologies. So this is a very important definition to start off with. So this entity was first described in 1954 after a patient who became oliguric after the use of contrast media. That patient happened to be of multiple myeloma. So overall incidence of this varies. So I'll come to the incidence later on. So as it is suggested that around 2.32 it can range to up till around 16% cases, and amidst them, nearly around 50% cases of area almost PCI induced renal injury could be attributable to contrast. So exact definition and data is variable. So now I'll come to the individual components of this entity. So why is it important for us to know that it is associated with increased morbidity and mortality? Because if there is a persistent renal dysfunction, there might be increased persistent AKI, and that might lead to dialysis, and there might be metabolic problems, so on and forth. Secondly, it is also important that the contrast-induced AKI is prevalent in the patients undergoing percutaneous intervention and non-percutaneous coronary angios. I mean, wherever there is a coronary intervention not done, however, an angiography is done. So in those cases also, it is very much prevalent. The creatinine usually after starting, it usually peaks by around 2 to 5 days, and it's usually transient. Most of the time, it's transient, and it basically normalizes by around 7 days. Some say that till 1 to 3 weeks it can normalize. So the traditionally we measure it with basis of creatinine, but yes, we can use the newer kidney injury molecules like NGAL, neutrophil gelatin associated lipogalactosamine, and similarly we have the kidney injury molecule. So these are the few molecular markers of renal injury. There has been a lot of controversy regarding whether it is contrast induced AKI or it's a contrast associated AKI. As I said, because I'll complete this in the later part, that uh, as per many intensivists and nephrologists, contrast-induced nephropathy is actually a myth. It doesn't exist. So in this sense, it is mostly advisable to use the term CAAKI. Obviously, it is medico-legally important because if you are giving a contrast to a patient, you will have to explain to the patient relatives that there is a certain associated risk of nephropathy after the use. Now coming to the pathophysiology, so the contrast media, it mostly in the historically we are using hyperosmolar iodinated contrast media, and their osmolarity used to range somewhere between 1500 to 1800 milliosmoles per kg, which is almost 7 to 8 times higher than that of the human plasma. So because of the higher osmolarity, it was highly viscous, and it has got cytotoxic properties. So it causes damage of the tubular endothelial cells, and also it produces lot of reactive oxygen species.
এটা
Because of
হয়েছে
there is
জানি
a
না, চুরিটা হয়েছে জানি।
because of vasoconstriction, because of the increased viscous nature, it also clogs the renal tubule, reduces the renal tubular blood flow. So on the same time, it reduces the blood flow to the tubules, it clogs the tubules, reduces the GFR, and ultimately culminating in medullary ischemia and nephrotoxicity. So reactive oxygen species mediated damage is very important for that purpose, and that the organelles which are higher in mitochondrial content, especially the medullary ducts, the medullary collecting ducts, the medullary thick ascending loop, they are more prone for hypoxic damage. The higher osmolarity contrast media, as I said, they have the viscoelastic and the osmotic diuretic load. They got tubular block, increase the intertubular pressure. They also mimic a scenario where they are almost as similar to a saline load to the distal convoluted tubule. And because of the negative glomerulotubular feedback, there is a decrease in the afferent glomerular arteriolar flow, reducing the overall renal blood flow or the GFR. So that also aggravates the injury, and it also damages the vasa recta. So overall, reactive oxygen species, vasoconstriction, tubular damage. This is again a pictorial representation of whatever I just said. And to add to this, to a finer touch, is that there is an imbalance between the vasoconstrictors and the vasodilators. So the levels of endothelin, angiotensin 2, they go up in the renal milieu, whereas the levels of nitric oxide synthase and vasodilators like prostacyclins, they go down. And that results in again the more of a vasoconstriction, decrease in the GFR, and so on, those things. Now coming to now the risk factors. So now comes the most important concepts of a contrast-induced or contrast-associated AKI. So the first and foremost is the higher osmolar media, higher osmolarity media, and higher volume of use of contrast media. So if you are using a higher osmolar media, which was historically used as the more than 1500 milliosmoles per kg used to be there osmolarity, they had something known as the lower iodine and dissolved particle ratio. So they had lesser amount of iodine versus they used to give rise to a lot of dissolved particles. They used to contribute to the osmolarity of the serum, and they were damaging because of the viscous nature. Generally, the higher osmolar agents has a lower iodine to dissolved particle ratio. So they have a ratio of 1.5, and the lower osmolar or the isoosmolar agents have higher ratio. So again, I will reinstate this. So the higher iodine and is to dissolved particle ratio, it is the better. So similarly, the low osmolar contrast media, which the contrast, although they are called low, however, their osmolarity is slightly higher than the human plasma. So it's in the range of around 500 to 600. So they are actually hyperosmolar, but lower as compared to the previous ones. They are much more preferred, especially in patients who have a pre-existing chronic kidney disease. Now, in subsequent slide, I will let you know that there are few groups of patients who are at very high risk of developing a contrast-associated AKI, and pre-existing chronic kidney disease is one such subset. In the right hand side, I've put down all the risk factors that are modifiable or the non-modifiable risk factors associated with CAKI. Non-modifiable are the advanced age, diabetes mellitus, heart failure with reduced ejection fraction, low cardiac output states, patients with pre-existing renal transplant, post-renal transplant status, that's mean, and some modifiable risk factors like if you're giving nephrotoxic drugs again and again, you're giving NSAIDs to the patient. Hypoalbuminemia. So this is a very important thing to highlight. This is not only applicable for CIN, it is also applicable for other diseases as well, that hypoalbuminemia has been associated with worse pulmonary outcomes and worse renal outcomes. So this is, although not directly related, the hypoalbuminemia part also contributes a lot to the nephrotoxic potential. Also, the higher volume, as I said, higher osmolarity, and the repetition of the on contrast media. This I have again repeated in next slides. So there are, what are the types of agents that we use? Most frequently in normal days, we are using iodinated contrast media. The iodine, the contrast media that we use either is an iohexol or it's an iodioxonate. So it's either of the iohexol that we use, this one, or it's an iodioxanol, or sometimes we can use iopentol. But this previous agents which had the higher osmolarity and it had got a monomer benzene ring, the dietrozoate, then we have the ioxaclate, these are not used nowadays. Most commonly the iohexol and the iodioxanol is used. This is highly preferable. Now coming to the higher versus lower osmolarity effect, as I just said, that the lower osmolarity and the isoosmolarity is preferred, especially in patients having pre-existing renal dysfunction. So as seen in this study by Aspelin et al., the nephrotoxic effects in high risk patients undergoing angiography, which showed that patients who had previous diabetes and chronic kidney disease, so more of a diabetic kidney disease with a pre existing renal dysfunction, undergoing our angiography, the risk of AKI was almost 9 times higher for iohexol group than for the iodioxanol group in patients for patients with risk factors. So even in these cases, if you are using a low molecular or an isoosmolar agent, it is better than what we commonly use. So similarly, there was another trial, the Recover trial, which showed that the isoosmolar was better. So just to again emphasize the fact that isoosmolar is having the lowest osmolarity. What we call the low osmolarity is actually the medium level osmolarity. What are the other risk factors? One is the age related, patient related, sorry. So the age more than 70 years, chronic kidney disease, diabetes, hypertension, which were obviously previously mentioned in this slide. So here, these are all things are mentioned. Again, I have written here, hypoalbuminemia, female sex, and intraarterial balloon use. IABP use per se. So here the one catheter, one balloon along with some assembly. So this catheter is introduced percutaneously inside an aorta via the arterial route.
मेरे अरबिक सर कुछ नहीं लिखे.
It's mainly used for heart failure with reduced ejection fraction, and there are particular indications for it. So the use of IABP itself, other than associated low ejection fraction or low cardiac output states, there is also some blockage of the renal arteries, and that can also lead to the nephropathy that is seen with IABP. So particularly IABP with a contrast agent, very high risk of CA associated AKI. There are procedure related, so urgent, more chance of nephropathy because we don't get the time to optimize, percutaneous interventions, intraarterial injections, and repetition. So I've mentioned in following slides that if you're giving a contrast on day one, you cannot repeat the contrast till 72 hours. That's 3 days. So at the earliest that you can repeat a contrast mediated, or I mean contrast based any kind of diagnostic study is 72 hours afterwards as per the recommended guidelines. Now, having said the risk factors, there are certain risk factors or the markers which predict a persistent damage. So they are rapid rise of creatinine. So if you have a baseline creatinine of somewhat say 2 or 3, rises to 6 after the use of contrast, definitely this is going to get worse in the future. Persistent elevated urine NGAL levels. If the contrast media volume is to EGFR ratio, that's usually more than 3.45. So if your EGFR is suppose 25, you are expected to give somewhere around 80 to 90 ml of contrast media. If you are given it 150 ml, there would be chance of damage. And obviously patients with heart failure with raised proBNPs, it means some kind of myocardial stress, pre-existing diabetes and CKD. So these are risk factors of having a persistent damage and oliguric AKI or CKD progression, CKD 5D stage where you require some form of dialysis. Again, to just a kind of a repetition with some finer touch is that what are the risk factors? So CKD stage 4-3, active renal failure, established cause of particular some causes of CKD like membranous nephropathy, IgA nephropathy, and the features we have already discussed. Now comes, can we predict that in which patient the risk of CIN or CA associated AKI is higher? So there was one scoring system proposed by Mehran et al., which is not widely validated, although there are two scoring systems. One of them is this one, and this is done in patients who are undergoing PCI. So what is the risk of having a persistent renal dysfunction in patients undergoing PCI? So the risk factors are enumerated here. So age, baseline serum creatinine, hypotension, IABP use, which most of them I have already enumerated. So they have put across all these factors, and they have come up with a score, the CIN risk score. And if the CIN risk score is low, say less than 5, the risk is obviously lower. If the risk is high, say more than 11, then the risk of CIN goes up till 26% from somewhat around 8% with low CIN score, and the risk of dialysis also increases. And if it is a very high risk score of more than equal to 16, the CIN rate is almost as high as 58%, and dialysis requirement is almost as high as 12.6%. And I'll emphasize here that the patients generally CIN is a transient thing. It goes away even if you think that contrast is actually causing a renal damage. But if it stays and the patient progresses to a stage of complete renal shutdown and require dialysis, those kind of patients do not perform well in most of the time, and this dialysis requiring patients can have a high mortality. So generally, it's a benign thing, debatable thing. Nonetheless, if there is a progression, it can land up in a very bad state for the patient. What are the other diagnostic workup that we think of? So we diagnostic workup is the causes of other causes of ATN or AKI we have to rule out. So differential diagnosis, like we have to send creatinine. If we are able to send, we can send the newer markers like the NGAL, the TIM2, the kidney injury molecule, the liver fatty acid binding protein, so on and so forth. And definitely, what is important in current literature, what is obviously missing, what the KDIGO guideline doesn't tell us, is that we have to adequately load the volume inside the patients when undergoing an angiography or a contrast mediated procedure. But this volume is individualized. It is not some blanket therapy that we give to patients, especially in the era of ultrasound and focus. So always assess the volume of the patient before and after the contrast associated or procedure is done, and devise or plan out your fluid management accordingly. There is others, two or three other indices which I've come across. I was not aware of them. One of them is the triglyceride glucose index. So fasting triglyceride and sugars, they're multiplied by 2. So if that is higher, that indicates that the patient has, as per one meta-analysis, they have a sensitivity of 77% and specificity of 55% of predicting contrast-induced nephropathy. Uh, this scoring system is a newer one which can be used, or if someone is aspiring for some competitive exams, this can be asked. The clinical features, so other than the rise or rise in creatinine, is usually non-oliguric. You can see cellular cast, granular cast in the urine sediments, but you will never see WBC cast or eosinophil cast, which are suggestive of inflammatory, infective process or an acute interstitial pneumonitis, acute interstitial nephritis. And a very important last line to remember, that it has to be differentiated from atherombolism. When I'll discuss about the myths of a contrast associated AKI, I'll discuss this point in some details. So now continuing with the talk, that we have discussed about the definition, we have discussed what are the risk factors, and now we will talk about the prevention. I will focus much on the prevention because treatment per se is not there. I mean, other than removing the much contrast media via modes of dialysis and providing renal replacement therapy, we can't do much. So what are the preventive strategies? First of all, using alternate diagnostic techniques. If we have other techniques like a non-contrast CT which can give us the same data, we can use that. We have to minimize the amount of iodinated contrast media. Now, one formula I've already mentioned, that what is the maximum volume that we can use is generally it's based upon the patient's EGFR. So the volume by EGFR should not exceed 3.45. Similarly, there is another volume that tells us, another formula, that the maximum contrast volume, allowable contrast volume, is 5 times of the body weight divided by serum creatinine. So in CKD patients in whom GFR is somewhere in the range of 20 to 30s, like stage 4 CKD, there the amount of maximum permissible contrast media is in the range of say 70 to 20, even 20 to 30 ml may cause AKI, and the permissible limit is maximum 80, 70 to 80 ml, so it's less. So if you are using a volume of contrast media less than 100 ml, usually the risk is, as I previously mentioned, so there are risk scoring system. Based on that, it can range somewhere between 1% to 30%. But for every 100 ml extra over and above the 100 ml that we have used, it adds around 12% extra risk. But seldom we use a higher contrast volume, and so most of the time the lower contrast volume of 60 to 80 ml is sufficient for most of the studies. So we seldom go to that extent. And do not repeat less than 3 days, and use of obviously iso or low osmolality is preferred. So this one I have already mentioned, the lack of, but what I will discuss again in the myth section is that, do modern day lower osmolality contrast medium really cause nephropathy? So this one I'll skip. I'll again come back to this point when I'll discuss the myths of it. So coming again, continuing the preventive strategies, if the patient is on some form of drugs like ACE inhibitors or ARBs, which interfere with the local milieu, the afferent and the efferent glomerular arteriolar nature of vasoconstriction, so those things has to be stopped at least 48 hours. Now there is no hard and fast data to support it. However, it is advisable that because ARBs and ACE inhibitors are known to cause nephropathy and alter the renal milieu, and because you're giving a second renal toxic agent, so in those cases, it is preferable to use it before 48 hours or stop it during the procedure. Similarly, drugs like metformin are advisable to stop 48 hours prior to contrast use. However, I have not mentioned that in MRI we use contrast known as gadolinium, which is associated with nephrogenic systemic fibrosis, which is a bit different than what we use in CT. And although the no, CT contrast, the iodine-based contrast, is generally benign and short-lived after effects, the gadolinium, if it causes an NSF, non-systemic nephrogenic systemic fibrosis, it can be very deadly. So in those cases, or you can use metformin. In MRI, if you're using a contrast, you can use metformin. But if you are using it for CT guided procedure, CT contrast, it is preferable to avoid it at least for 48 hours. And use of other nephrotoxic drugs and mostly the NSAIDs has to be avoided. Now coming to the preventive, this is therapeutic options, but this we use as a preventive strategy. So that's why we included in the prevention. So what are the therapeutic options per se? So the agents that have been used are various, at least 10 to 15 agents have been used. To name a few, soda bicarb, N-acetylcysteine, statin, vasodilators, forced diuretics, renal replacement therapy, IV fluids, allopurinol, and trimetazidine. Now I'll come to the individual points and discuss briefly on each and every individual components and their evidence. So uh, coming to NAC, so N-acetylcysteine. So benefit of from a NAC dose is usually seen initially that there are some studies which show that NAC was beneficial. The dose I have mentioned again in another slide is usually 600 to 1200 uh, 600 to 1200 milligrams oral capsule. Generally, we give four such, two such given before the procedure, two after the procedure. There was one trial, preserve trial, that was a factorial trial based on NAC, soda bicarb, and saline. So there was 2:2 factorial design, which ultimately showed that NAC probably was associated with some uh, benefit in terms of reducing the risk of CA associated AKI. However, whether it is truly a beneficial effect, people doubt it because NAC has been shown to alter the creatinine metabolism and the transport, and mostly that it interferes with the anion transporters, organic anion transporters, and so therefore the creatinine reduction might not be an actual renal protective effect, because many studies have shown that cystatin levels, which are present in all nucleated cell in our body, in one of the markers of glomerular damage in kidney injury, it remains the same. However, because it is a cheap drug and it is very easy to use, easily available, and there is no risk of harm, obviously, KDIGO guidelines 2012 still recommends the use of a NAC. So there has been trials which have used NAC plus saline, NAC plus furosemide, NAC plus bicarbonate, all kinds of formulations have been used. Oral and IV NAC are interchangeable, but uh, it oral, if you are using it, that is also acceptable. If you are having an IV option, you can also use that. Now coming to the most important category 1 or grade 1 recommendation to prevent contrast associated AKI is to maintain an adequate hydration. So traditionally people were using saline, and usually the saline loading was associated with lesser amount of AKI after use of contrast media than of not using any IV fluids. Usually it started 6 hours prior to the procedure and completed by 12 to 24 hours post procedure. If you are having a lack of time, then usually you give a bolus just 2 to 3 hours prior to the procedure, and you give the reminder of the fluid after the patient has come back to you. And regarding the type of fluid, it is preferable to use normal saline rather than using a half normal saline. There has been trial which showed that normal saline use was slightly better than half normal saline. And in modern era, don't blindly give fluids based on some body weight and some formula. Always use your IVC ultrasound and the diastolic pressures and the echo, everything we have to see altogether. So this was one so-called protocol for using the saline. That's you start with around 1 mils per kg per minute per hour, 1 mils per kg per hour. So a 70 kg body weight patient receives around 70 ml per hour of fluid. That should be started 12 hours prior, continue 12 hours afterwards. If the patient is in heart failure, you have to reduce the volume to around 0.5 mils per kg per hour. And if it is an emergency procedure, you give a bolus at 3 mils per kg. So that's around 200 to 300 mils of fluid. And you continue the rest of the hydration after the procedure is over. Now that's then coming to the next part. As I said, that you have to tailor your fluid amount based on your what you see on the ultrasound. And there was a one nice trial which was conducted in 2012 called as the Poseidon trial. Uh, uh, this Poseidon spelling is wrong. This should be POSEI. Sorry for that. So here they have used a pre-hydration of saline at 3 mils per kg per hour before the procedure has started. Now they have divided the groups into two groups, the patients into two groups. One is the control group, and one is they have used the terms sliding scale type fluid administration. So in one group, they have given 1.5 mils per kg per hour fluid. So usually around 90 to 100 ml per hour fluid they have started. 3 hours prior to the procedure they have started and continued 12 hours afterwards. And in another group, they have measured the LV end diastolic pressures. And after measuring it, they have devised their fluid strategy on what is the amount of LV diastolic pressure. If the LV end diastolic pressure is very high, say more than 18, which is indicating our left atrial hypertension or incipient pulmonary edema, they have reduced it to 1.5 mils per kg per hour. Whereas if it is low, they have given 5 ml per kg per hour. And that has shown that this particular intervention group was associated with slightly lesser risk of AKI, probably because of a much more tailored and minutely manipulated kind of a fluid regime. Coming to other therapies, so again I'll repeat whatever I've said previously. If you have to remember one thing for CI-associated AKI as part of preventive therapy, it is fluids, IV fluids, and preferably a saline. Now coming to the other data, and I'll discuss about the some other kinds of fluids which we can use. Now, coming to other preventive strategy, one is use of statins. There has been some data which show that short-term use of rosuvastatin in patients with have been shown to have preventive effects on AKI after patients with diabetes and chronic kidney disease. Again, the overall data and the cumulative data doesn't show much of a benefit. In one study, the positive trial which found that around 3,000 patients using rosuvastatin 10 mg 2 days prior and usually 3 days afterwards associated with lower risk of AKI. Again, this was purely an OPD based procedure. We don't expect a patient in a hospital waiting 2 days just to be on the safer side of a procedure, just to be on the safer side before receiving a contrast media. So my question is this: when I've gone through this article, that they have used rosuvastatin in patients with diabetes and chronic kidney disease, and this was done for coronary intervention. So is this the effect of on the underlying CAD, or is it actually the preventive effect on nephropathy? I'm yet to find that answer. So again, statins not much of a news. Now preventive strategy: what is the role of bicarbonate? Theoretically saying, there is something known as a Haber-Weiss reaction, where alkalinization of the urine reduces the reactive oxygen species formation. And since reactive oxygen species is one of the cornerstone of damaging the ways of damaging the renal tubules, reduction of ROS leads to a renoprotective effects. So bicarbonate theoretically should reduce renal tubular damage. But again, as the data suggests, there is no hard and fast benefit. One retrospective study found that even with the use of bicarbonate, there was more chance of AKI. But they have not, because this was a retrospective trial, they have not given a hypothesis as to why this was happened. They said that it needs to get investigated further. There was one trial, Compass RCT, where no prehydration with bicarbonate was compared, and they shown that the second later group had some benefit or some beneficial effect on the AKI. However, the main drawback remains the same, is that they have given prehydration with bicarbonate. So whether the hydration part is helpful or the bicarbonate, it is again debatable. What is interesting is the use of concentration 1.45% bicarbonate. So when you are using a bicarbonate for preventive strategy of CA-associated AKI, we should use it as a this concentration. This is called as an isotonic bicarbonate. How is it prepared? So it is prepared by mixing 150 milliequivalents of bicarbonate, that is concentrated 8.4% bicarbonate, with 850 ml of 5% dextrose. The moment when you mix it, it becomes a 1.4%, which is almost 1/4 of what we normally use as a bicarbonate. So this is just the advantage of being isotonic. It can be used by the peripheral lines, And other than some transient hyperglycemia, it is safer to use theoretically. In patients with acidosis, renal dysfunction, bicarbonate therapy has been shown to be somewhat beneficial. So, in these cases, if you are using a fluid, you can use either saline or you can use a bicarbonate fluid. Again, the main focus would be the hydration, not the bicarbonate component per se. The concentration is 1.4%. Now, coming to some interesting thing that I've come across, that there is something known as a renal guard system, which is being used. Now, this has been used in the case of NICIN. However, it has been used as an extracorporeal blood kind of management strategy in many other cases also. So, this has a basically a console, and it has got an IV drip set which is connected to the patient, which is a sort of single use, and it has got a catheter system which is specifically attached to the patient's Foley's, and you measure the patient's fluid output. So what you do here is that you give some saline, you also give some diuretics, and you give NAC. This triple therapy has been shown to reduce the incidence of CIN as compared to only NAC plus bicarbonate. And the console itself, why is it used? That the console itself controls what is the amount of infusion that we have to give, what is the amount of urine. Suppose the urine comes higher, urine output is high, it will increase the IV infusion rate. If it is low, it will reduce the IV infusion rate. So it's kind of a closed loop feedback system to optimize your fluid management and urine output strategy. So next, coming to what is the role of renal replacement therapy. As per KDIGO, there is no routine role of using a RRT. It should be used only if there is an indication for AKI. Now, few interesting points. One is that all the dialysis modes with current kind of contrast media and the current kind of membrane pore size removes around 50 to 60% of the contrast media use. So contrast media is dialysable. However, the so-called benefit of using a routine RRT is not there. It's because that by the time, the moment you push a contrast media, it immediately reaches the kidney, say around 2 cardiac cycles. That would be what, around 2 to 3 seconds maximum. And by the time it has already gone and bound to the kidneys, and it will not remove from there immediately. So when you start a dialysis around 4 to 6 hours after, it will hardly have any effects. So even if you want to use, it can be used for AKI reasons. In patients with pre-existing renal dysfunction or severe heart failure, you can use it. There are some data showing some benefit is there. So again, I'll just reinstate that RRT renal indications definitely use patients with pre-existing CKD. You can use contrast and then afterwards go for dialysis. And in modern era, we can also use a filtration-based strategy like a continuous veno-venous hemofiltration, which also removes the higher molecular weight substances. It can be added. Now, coming to few tidbits about some other not so conventional therapies. So, role of vasodilators like phenoldiazepam, not so much role. It has one study showed that some benefit is there. It is a selective beta one agonist, and sorry, dopamine receptor D1 receptor agonist causes renal vasodilatation, but not so much of a useful. There is one trial which showed that using nitrates reduces the risk of CIN, and the data was quite promising. But again, there is not much of a role. Recently, SGLT2 inhibitors, which has been the cornerstone of management of all kinds of heart failure and CKD patients, and trimetazidine. This has been investigated, but not much of a data yet. Now, coming to the last interesting part about this topic is, does CIN actually exist? All we had discussed till the last 30 or 35 minutes about the topic, and at the last I have to say that there is a huge amount of researchers who are of the opinion that this is actually a myth, that doesn't exist. Why so? Because during the inception period, so this was associated with higher molecular weight contrast media. We did not have lower molecular weight contrast media then. So nowadays we are using low molecular weight contrast on an isoosmolar contrast, and it has been shown, as I said previously, one trial, that there was actually no risk of a contrast-induced nephropathy with a low molecular weight substances that we use. Secondly, that creatinine is actually diabolical. So this was actually the trial that I was talking about, a cohort analysis of contrast-mediated media, and they've shown that actually the so-called risk of contrast-associated nephropathy is hardly existent. Secondly, we are using creatinine as a marker of renal dysfunction. This is highly debatable. We know for sure that The other better markers of kidney injuries are there. It is being used as research and many other centers. There is something known as Nephrology, which is a multiplication of TIM2 and IGFP beta 7, which is a better marker of kidney injury and predictor of kidney injury. Creatinine has a lag period of say 24-48 hours before actually rising, and plus it is also dependent upon the transporter, so some amount of reabsorption transportation, so it's a diabolical marker in a nutshell. So using creatinine solely to say okay this patient is worsening or patient is improving is a problematic thing. And it is again seen more commonly in patients who have a low ejection fraction, CKD with some kind of cardiac dysfunction. So whether it is because these patients are inherently sicker that they tend end up being dialysis dependent or having an AKI, or is it purely because of the contrast, we don't know. That's why nowadays what we are that what we currently are you saying is that don't use the contrast induced nephropathy term, rather it is safe to use contrast associated AKI term. So this concludes the topic of contrast induced nephropathy or contrast associated AKI. I'll move on to my next small talk on rhabdomyolysis. It is a small interesting part, and it is an acute breakdown of skeletal muscles, and because of which the myoglobin is gets released into the bloodstream, and because of the myoglobin and multiple others muscle pigments, it causes acute tubular damage and AKI. The renotoxic material, it is very important to note that the myoglobin are the and the other heme pigments which causes acute kidney injury. It is not only because of the obstruction or the physical mechanical obstruction that they cause renal damage. Biochemical factors are also responsible for the damage. So they go and they clog the tubules, causing increased glomerular intratubular pressure. Along with that, they release the vasoconstrictive substances and increasing the resistance of the arterioles, and thereby causing a milieu, thereby that is inherently damaging for the renal parenchyma. Other causes, now coming to the most important thing, what are the causes? So there has been an exhaustive list of drugs which are associated with rhabdomyolysis. I have highlighted the ones which are more commonly involved, and if anyone is asked in exam or facing in real life, they should know about 4 to 5 drugs which are commonly associated. The first and foremost, the statins and the fibrates. So any form of statins, atorvastatin, rosuvastatin and all, everyone is implicated. Rosuvastatin and all the newer analogs are slightly lower, but again they can cause. Antipsychotic medications like haloperidol, escitalopram, desvelnafexine. I have personally seen patients taking SSRIs and landing up in AKI with rhabdomyolysis in my DM training program. And there has been other antibiotics such as daptomycin, cotrimoxazole, and tenofovir. Among these, daptomycin is very important to remember, which can cause rhabdomyolysis. And among the toxicology causes, sympathomimetic drugs and snake venom, especially snake venom, which can cause blistering and rhabdomyolysis and AKI. Now, the physical injury also causes. Among the physical injury, the most foremost or the most common cause of rhabdomyolysis throughout the world would be a crush injury, and it should be the crush term has to be emphasized. It's not a blunt road traffic accident. Some portion of body, the limb or body or abdomen, has to come under a heavy object in order to get crushed, so that the huge surge of myoglobin is in the body. Electric burns is another important thing to consider. The electric burns can be deceptive. Their depth are not easily gauged just by looking at the wound marks, and they can cause severe damage to heart as well as the skeletal muscles. So electric burns is a very common cause. In ICU, prolonged immobilization can sometimes cause a muscle damage, muscle lysis, and they can cause. Now coming to excessive muscle activity, for example, marathon runners can have some extremes of sports. Marathon running can cause rhabdomyolysis. Status epilepticus and asthmaticus, if it is not dealt with properly and the patient is kept in that condition for hours, they can land up in rhabdomyolysis. And serotonin syndrome, the muscle hyperactivity syndromes like serotonin syndrome, neurolopathy syndrome, they can also cause. Dysthermia, like hyperthermia, patients with severe heat stroke can also cause rhabdomyolysis, can have rhabdomyolysis. And interesting to note that few of the dyslipidemias can trigger the rhabdomyolysis. Now, and I mean, it is astonishing to see the list of dyslipidemias that lead to rhabdomyolysis is almost everything. hypokalemia, hypo and hypernatremia, hypophosphatemia, hypocalcemia. Everything can lead to a rhabdomyolysis. And plausible reason being that the disbalance of electrolytes kind of alters the milieu or the electrical charges around the membrane, alternating the membrane action potential, and thereby leading to some form of depolarization, muscle action potential alteration, and kind of a muscle lysis. So this is because of the alteration of the muscle action potential. And just note that I'll discuss later that rhabdomyolysis causes release of potassium, myoglobin, phosphate, etc. So hypokalemia and hypophosphatemia leads to muscle breakdown. The moment the muscle breaks down, they will increase the potassium and phosphate levels. So similarly, hyponatremia, as I said, hyperthyroidism, other causes where you can see rhabdomyolysis, and the infective causes of rhabdomyolysis are mostly you have to remember influenza that is very commonly associated. In our setup, dengue. Dengue is a very common cause of rhabdomyolysis. Other than that, Staphylococcus aureus, soft tissue infections, uh, gram-positive anaerobic infections by Clostridial species, mycoplasma, and autoimmune disorders like dermatomyositis, polymyositis can cause. Now, this picture, this particular slide tells us about how you diagnose a case of rhabdomyolysis. So, there has to be some pre-existing condition where we suspect, okay, this patient might have a rhabdomyolysis. So, that can be some form of a crush injury or some drugs or hypothermia presenting with an acute kidney injury. And remember that AKI, this one, here we see that the AKI is very drastic. I mean, AKI developing within few hours or probably less than 24 hours, and I mean, progressing to from stage 1 to stage 3 very rapidly. Along with that, if you do a dipstick of the urine, it is falsely positive for heme pigment. So it is showing that hematuria is there, but once we look at the urine analysis, microscopic analysis, we don't see any RBCs. So positive heme dipstick in the urine, but lack of RBCs in the urine point towards a diagnosis. Now, what are the muscle symptoms we should be looking out for? If there is a patient who is having a crush injury, complaining of pain, we don't have to think much. His CK levels are elevated, AKI is there, it's a rhabdomyolysis. But if the patient is in ICU, they might not complain about a pain in a particular region. Or if there is a non-traumatic cause, drug associated, we should always look out for few things like muscle pain, which is present around 12 to 20% cases, muscle weakness. Weakness of proximal muscles can indicate an underlying dermato or polymyositis condition, and muscle crepitations. So when you palpate the muscles, you see some kind of crepitation, crackling, kind of egg crackles kind of a thing feeling under the muscles. And there can be induration as well. In snake bite especially, we can see blistering. Now, what we in labs, what we majorly see is that we see the creatinine kinase. I'll come back to the lab findings later. And the most, sought out thing, although it is not always present, is a dark cola colored urine. The myoglobin, which is released into the urine, it is less bound to proteins and more freely movable into the urine. So within hours, you get a very dark cola colored urine. However, it is present in around 30-35% cases maximum, and it can be negative as well. So the true brown urine and dipstick is positive, however negative RBCs. So this entire picture of per typical rhabdomyolysis is by urine picture is present in 5 to 12% cases. The entire triad of muscle symptoms, raised creatinine kinase, dark colored urine is present in 35 to 40% cases only. So again, now coming to the description of the lab values. So creatinine kinase or the total CPK, that is creatinine phosphate kinase, either way can be used. Do not confuse the CKMB as a marker of rhabdomyolysis. CKMB is released mostly from the cardiac myocytes, and the what we need to check is the total CK fraction or the total CPK levels, not the CKMB. We don't measure the CKMM fraction, which is actually should be measured. And in these cases where total CPK is elevated, their isoform CKMB is also somewhat elevated. So don't confuse with the MI as a causative agent. Diagnosis is done generally if it is more than 1000 international units per liters. But in most of the cases where it is established beyond 48 hours, a value of more than 5000 international units per liter is expected. Now coming to some of the drawbacks of a creatinine kinase usage. So we expect that a rhabdomyolysis patient will have a raised creatinine kinase, but it has a slow rise. it usually rises by 24 to 48 hours. And usually the half-life is 36 hours, and therefore it comes down to normal also in a slow manner. Therefore, you cannot use creatinine kinase to guide your therapy in a patient with rhabdomyolysis. It just helps to diagnose the case. It puts a stamp on the paper that, okay, it's a diagnosed case. It does not add value to your early diagnosis or treatment. Secondly, uh, we can use LDH. It can be elevated. Again, it is highly, it can be elevated in any cellular breakdown, not so much of a specific thing. An isolated elevation of aspartate transaminase, the liver enzyme. So aspartate transaminase is released from the, other than the liver, it is released from the heart, the kidneys, and the placenta. We don't measure the individual fractions, but in a non-pregnant patient and patients without a cardiac dysfunction, if AST is elevated out of proportion, then ALT or isolated elevation, it has to be a muscle as a source. Myoglobin. Coming to the myoglobin, we don't measure the serum myoglobin because it peaks very rapidly within 2 to 4 hours and goes down very rapidly within 24 hours. We can measure the urine myoglobin. It is a very early marker of rhabdomyolysis, usually done within 24 hours. So, if you have to diagnose a patient, then we have to send urine myoglobin first, preferably immediately as soon as possible after the presentation. And afterwards, we can send the CK levels to confirm our diagnosis and to have a concrete establishment as to the cause of the diagnosis. Urinary myoglobin theoretically can be used to target your therapy, but it's so briefly sustained that we cannot use it as a guide to therapy. CK levels, it again should not be used as a sole marker to guide your therapy. Now, coming to something more interesting, as I said, now there is a dilemma. CK generally elevates after 24 to 48 hours, and the usual management should start immediately when you suspect rhabdomyolysis. So, in this case, suppose a patient has come with crush injury at T0, by 2 to 4 hours, his CK level will be barely touching thousands, and you will be confused that patient whether to treat this patient as rhabdomyolysis or not. By end of day 2, you see that CK level is 10,000. Patient has gone into full-blown AKI hyperkalemia requiring dialysis. You have missed out a window of 24 to 48 hours. That is because of the drawbacks of CK. Myoglobin for diagnostic, okay, but we don't generally use for therapy. So in cases where the CK levels are not established as high, what you can use is something known as a McMahon score. So this is particularly useful for intermediate to high risk category patients. This is a pre-test probability of having rhabdomyolysis. So what are the scores? It has got 8 components: age, female sex, initial creatinine, and the serum electrolytes, serum calcium levels, phosphate, initial bicarbonate, total CK levels, and rhabdomyolysis is caused by particular factors or not. I'm not going to the individual components. I have put down this link. If you just click on the link, you will go to the MD Calc and you can calculate yourself. If it is more than 6, then it is called as not high risk. It is called as not low risk. Means that you are not sure it is rhabdomyolysis or not. You should treat like a rhabdomyolysis with adequate hydration and other associated therapies. This one I've taken for Internet Book of Critical Care from the MCRIT site, that what's a reasonable approach for these cases. So if you're having a high index of suspicion of rhabdomyolysis with muscle pain, cola colored urine, background of crush injury, some particular drugs, isolated elevation of AST, you should send the CK level, send for renal parameters and all the electrolytes. If the CK is more than 5,000, it's established, you start treating as rhabdomyolysis. If there is 1,000 to 5,000 where you are doubting, then use the McMahon score. If it is high, then you treat as rhabdomyolysis. This is how you should tailor your therapy. Now coming to the role of POCUS. So it is an interesting thing. It is not mentioned in most of the literature, that can we use our ultrasound to diagnose rhabdomyolysis? Absolutely yes, we can use it. So you see that there is a case, this is I have taken from a case report where a patient came with AKI hyperkalemia and they were unable to initially diagnose what was the cause of it. They found that there was some induration in the one particular cuff muscle. They put an ultrasound and saw that the muscle was inflamed, kind of, it was increased in the diameter, and it was having multiple hypoechoic areas with loss of typical muscle strands. On the right hand side, we see a normal muscle fibers. On the left hand side, loss of muscle architecture. So if these signs are there, this indicates that the patient is having a rhabdomyolysis. For confirmation, we can also use an MR and CT and get it confirmed by the radiologist. Differential diagnosis usually is other causes of ATN and AKI. and you should send urinary cast. You should rule out other drugs. You should rule out an inflammatory myopathy like dermatomyositis, polymyositis, or some cases immune-mediated myocardial myopathies. What's interesting here is that some cases the statin might not be causing. I mean, a single dose statin also can cause severe muscle damage because of an immunological reaction. So this is one thing that has to be kept in mind. And coming to the treatment, main is the IV fluid therapy. Now, you don't go by the, as I said, CK levels. Now, how to tailor your fluid therapy? This one is a Knight's algorithm, again taken from MCRIT side. That if you have diagnosed, you start the patient, you assess the patient's volume status, look at the patient's abdomen, look at capillary refill, urine output, use your ultrasound parameters, look at the volume status. If the patient is having hypovolemia to euvolemia, you load the patient's fluids and monitor urine output. If the patient has a urine output of say 100 ml per hour or more, you are safe to give fluids. You continue fluids in the range of 150 to 200 ml per hour. Now, question is what kind of fluids? Usually a balanced crystalloid is preferred. In like a plasma light or a ringer lactate is preferred. You can also use normal saline, but it is preferable to use a balanced crystalloid. If the patient is also having some acidosis, especially a normal and non-gap acidosis, that is where you can use a isotonic bicarbonate. Previously, I have in the class I have mentioned isotonic bicarbonate as preventive strategy in contrast-associated AKI. Here you can also use it for metabolic acidosis and rhabdomyolysis patients for fluid resuscitation. Again, don't blindly load patients' fluids if your urine output is not there. Look at the IVC, and if the patient is going in overload, you just stop the therapy and ask the nephrologist to initiate dialysis. So this is all about fluid therapy. So this one is again to the thing that when can we use isotonic bicarbonate? Isotonic bicarbonate can be used if there is no alkalosis. So pH should be less than 7.5, bicarb should be less than 30, and there should not be any hypocalcemia. If you are using bicarb, you give a lot of alkalinizing agents, and if there is hypocalcemia. Along with that, there might be hyperphosphatemia, and all these things can cause a clogging of the renal tubules by calcium phosphate crystals or calcium carbonate crystals to avoid if there is a existing hypocalcemia. Sorry, there is no role of mannitol or furosemide. Mannitol can be even harmful. And other than that, rhabdomyolysis can have significant hyperkalemia. So in those cases, we have to manage it. So that brings to the end of our class. I would expect if there is a question, anyone can ask me.
Acha, hello, good evening.
Yeah, yeah.
I have two questions.
Yeah.
The first question is, what is the gold standard of rhabdomyolysis? This question comes very often. And
Okay.
secondly, in nephropathy or CKD, whatever it is, in elderly patient, the recent studies coming up that cystatin C is a better marker, although
Yeah.
it's not available in the labs which we use. But in difficult cases, in elderly patients, the EGFR creatinine also doesn't give much uh, uh, information. So
Yeah.
there, do you feel the cystatin C can be a better choice?
Right. So I think what you said, your first one is a question. Second one is an absolutely, I mean, bang on statement. I mean, that is, I fully agree with it. Coming to the first question is that, I mean, the gold standard of rhabdomyolysis. So I have read few articles and I have read from Up to Date as well as from the MCRIT site. They clearly say that it's not a straightforward thing, and you cannot have a RCT on an rhabdomyolysis because it's a life-threatening scenario. You have to treat case to case basis. So there is
Yeah.
no such gold standard about anything of rhabdomyolysis, and that is why your McMahon score and everything comes into play. So again, you expect the patient with an underlying condition which can cause rhabdomyolysis, like statin use, daptomycin use, or crush injury with an AKI. AKI is so severe or acute, that is the acuteness is very important. If there is an acute patient having a pre-existing normal kidney function, comes to you within one day, you see that the creatinine has jumped very much. If significant hyperkalemia acidosis, definitely think about a pigment mediated AKI, that is particularly myoglobin mediated here. Secondly, if your CK levels, again, CK levels for initial phases might not be so much useful, but you can establish cases, it has to be high. A CK level, normal level cannot happen in an rhabdomyolysis case. It has to be elevated. And generally, it's elevated beyond 1,000 per liter. And a cola colored urine, if you're lucky, you can get it early period of trauma. So I have personally worked in a trauma center. where we used to send urine myoglobin immediately after when we suspect, and within say 6 to 12 hours, if it is positive, that means we have a green signal. Okay, we are going to treat in terms of rhabdomyolysis, and we used to load the patients with of fluids. And obviously, so this is all about the
No, no.
yeah.
Now, between the three choices, suppose if we are given rising CK and then myoglobin and MRI of the muscle, so which can be the best choice? Because sometimes questions come in MRCP like this.
Uh,
So in that case, which will be the best choice?
in that case, if it is an early diagnostic workup, then myoglobin would be the choice as per
Choice.
if yes, as per me, it should be the
Okay.
myoglobin. It is the best marker. But again, it
Best
by the time we are assessing the patients, 12 to 24 hours is gone, and myoglobin can be falsely negative. I missed out on an important
right.
point, is that if the myoglobin levels are very high, if it is very very high, it can cause a false negative heme pigment in the
False.
urine. Generally, why we check the urine dipstick, it is positive for heme and negative for RBC, it is rhabdomyolysis. But a very high myoglobin can cause a false negative heme pigment dipstick. So urine
Okay.
myoglobin checking should be done. That is the earliest gold standard for therapy.
Yes. Okay. Thank you. Thank you.
Yeah. And the second point you have just stated yourself, I mean, cystatin, NGAL, these are all, I mean, many hospitals are using it. Nephrotech is used in India, and for research purposes, people are using these molecules. These are obviously better than creatinine in all aspects, better predictive values, much earlier they detect the renal dysfunction. So if that is being
Great.
used, they individual components have their some drawbacks are there. So if that is being, they are much more preferable to predict.
Okay. Thank you.
Uh,
Sir, I
Aspirants?
have a question.
Yeah.
Sir, I wanted to know in terms of rhabdomyolysis, if a patient presents to us who doesn't have a pre-existing kidney condition, any AKI or something, but is on statin and has an infection at the same time, like kind of fungal infection or something, who has been administered with antifungals, and normally we get when statin-induced rhabdomyolysis normally presents with associated infections as well. So in that case, how to identify like the patient will have rhabdomyolysis or something like that? Means,
So again, the crux again here, we have to depend on the CK levels, total CK levels. Other than that, we can use a ultrasound. If you are lucky enough, we can pick out the ultrasound, because I suspect you are asking it because we are not able to do a CT on an MR. So patient is bedridden, on shock, something like that, sepsis, sick patient basically. In that case, we can
yeah.
use an ultrasound, and we can diagnose a compartment syndrome also can be associated with that. So compartment syndrome and a rhabdomyolysis can be identified with an ultrasound. If you don't know about anything, just compare with a contralateral limb. Just compare everything. If the
Okay.
limb is indurated, and if the patient is awake, complaining of excessive pain at some points, and on palpation you see that there is some crepitations that you can find, then the suspicion is high. Now you look at the CK levels if it is high, and then comes ultimately therapy. What to do? So there you use your ultrasound and overall assessment of the fluid status. And if you are on the the hypo or the euvolemic side, then you give fluids,
Mhm.
keep on are adequate. You do not put the flush out the myoglobin. Generally, 24 to
Right.
48 hours of therapy is enough. Don't target the CK for stopping of fluids. Don't target CK level
Okay.
should be less than 5,000 or 1,000 to stop. Initially, if you have given adequate amount of fluid and urine output is adequate for 1.5 to 2 days, you are good to go. That general myoglobin is flushed out. So that's how
Okay.
you can
So
kind of stop the offending drug. If you're thinking that statin is causing it, you might stop it.
understood, sir.
Yeah.
Okay. Thank you, sir.
Okay. I hope I don't think there is any more questions. So I will.
Aspirants, if you have any question, you may ask now. So I believe there are no questions. So
Okay.
we may end the session now. Thank you, sir, for being with us. It was a very nice, informative lecture. Thank you, everyone.